Hi guys, welcome back to week 11. This week we are focusing in on common musculoskeletal complaints, sports physicals, palliative care, and pain management. There was a lot of material this week. It's not as much as you think. I don't want you to get overwhelmed. I did break down the chapters in terms of specific pages I wanted you to review. So you'll notice within the module, it looks like a lot of stuff, but it's really just specific things I wanted to point out to make sure you're reviewing so that you can really differentiate the different systems in particular specifically for musculoskeletal. That was the one thing I really wanted to make sure to kind of give you guidance with in terms of your readings. There's about 48 slides in this lecture, so I'm going to try to get through it quickly. I don't want to hold you up from actually doing your readings, but I did want to point out some specific things in terms of guidelines. You will see that within the modules, there are definitely additional things for you to look at. So in terms of your musculoskeletal complaints, just make sure that you are reviewing the following tables and pages, and your book is listed here. You're going to want to make sure you are familiar with what key tests and assessments are utilized for each particular anatomical region, depending on the patient's complaints and presentation. Okay, so just make sure you know the specific tests for each particular region. Under your sports physicals in chapter 76, I did upload quite a few little supplementary materials that are specifically from the American Heart Association. Your book didn't get into the American Heart Association's role in sports physicals, but I wanted to make sure that you are aware that they provide a major, they provide consistent guidance and policies specifically for pre-participation cardiovascular screening of athletes, because one of the biggest things is just making sure that there's no cardiac issues, because cardiovascular screening is a huge thing within your sports physicals. Okay, make sure you're also reviewing what would disqualify an athlete from being cleared to play, which you'll find on page 1279 to 1280 on table 76.4. And that's very important, by the way, guys. It's so important. I'm going to just say it again. Please make sure you review what could disqualify these athletes from participating. You need to know what disqualifies, so that because you are going to be the person, the practitioner, it's your role to make sure that they are meeting all their guidelines to participate safely, not only for themselves, but for their colleagues as well. So you really need to make sure you know what would disqualify these athletes. And also you want to make sure you're reviewing your clearance categories on page 1279. The clearance categories are really going to differentiate, what your athlete is able to do or not able to do. So, and you need to make sure that you're very clear on that as well. Within the module, I uploaded a couple of pages I wanted you just to look at. I mean, you don't have to memorize this per se, but you do need to familiarize yourself with what a pre-participation history form would look like for an athlete, as well as a medical eligibility form, as well as I also uploaded the policy guidance from the American Heart Association that basically tells you why they are putting these things in action, because, based on evidence-based practice. Also, there's a very interesting article there that I think would help just familiarize you with how you would be speaking to these athletes or these prospective athletes. I uploaded this because I really want you guys to make sure you're familiarizing yourself with the verbiage and the language that you're going to use to talk to these athletes and their parents. Okay, because a lot of them are younger. Kids in high school that need to get cleared, or even college kids, or even middle schoolers. You need to make sure you're very firm on these guidelines and what would disqualify these students or athletes from participating, so that you can also explain it to the parents, because parents get extremely upset when they are told their child can't participate for whatever reason. So you need to make sure you're very clear on these guidelines, so you can reiterate that to both the student or the athlete and the parent as well. Because they can be bullies with this. I've done this before. I worked within a school district where we were in charge of both middle school and high school clearance, about 1,800 students, half of which the student body were illegal immigrants. So let me tell you, it made it extremely tricky clearing these students, because a lot of them were not even up to par on their immunization. So how do I clear them for sports, right? Parents were not happy, and neither were the students, and neither were the teachers or the coaches. But at the end of the day, it's our job to make sure these students are safe and are participating appropriately. So again, just review your clearance categories and what would disqualify these students or athletes from participating. We also got into Chapter 78, palliative care and pain management. And we will be talking a lot about the CDC guidelines in terms of prescribing for pain meds. So please make sure under Module 11, under additional learning materials, that you please review the CDC guidelines. And also there is a free app from the CDC that's really helpful in terms of prescribing. So I would highly encourage you to download that app onto your phone. The instructions on how to download it and where to get it are also listed under your additional learning materials in Module 11. Okay, in your practice guidelines, you review Chapter 18, your musculoskeletal guidelines. Please make sure you're reviewing how to assess and manage Cauda-Equina syndrome. That is an emergency, so please make sure you review that on page 632. The one thing we didn't put in your syllabus, which I want to make sure you look at, is Appendix C, the Tanner sexual maturity stages. You need to know how to stage females and males in their stages of development, depending on their puberty. I'm sorry, in terms of their development in puberty, that's how you would stage these particular students. And this is important because it is part of their sports physical. So Tanner staging is also known as sexual maturity rating, or SMR. And it's an objective classification system that providers use to document and track the development and sequence of secondary sex characteristics of children during puberty. This scale was first identified in 1969 by James Tanner, hence the name Tanner stages. He was a British pediatrician, and he, after a 2-decade-long study following the physical changes in girls undergoing puberty, he developed this this table. So due to natural variation, individual adolescents pass through the Tanner stages at different rates, depending in particular on the timing of their puberty and when they develop these sexual characteristics. So just make sure you review that table. Section 2, we got into musculoskeletal procedures, including diagnostic testing and procedures. You're going to want to look at some of the videos I uploaded that will specifically talk about your X-ray interpretation of bones, as well as your bone marrow aspiration and biopsy. Make sure you review page 128, 129 for your bone inspection. Okay, so now we're going to get into common musculoskeletal problems. So just in terms of an overview, I love this picture, by the way, of the common regional musculoskeletal problems. It just gives you a nice visual guide as to, the different areas of troubles. So musculoskeletal pain and dysfunction are some of the most common reasons for visits to a primary care provider. Because of the complex nature of these problems and the variable differential diagnosis involved, the actual number of people affected is difficult to ascertain with true accuracy. But in general, musculoskeletal problems are the most frequent cause of disability in workers, and population surveys show a greater than 50% prevalence of musculoskeletal disorders among older Americans. All right, so take care of your joints, heads up, right? Acute musculoskeletal complaints are generally self-limiting. However, some conditions, if left untreated, can lead to a cycle of progressive joint instability and a higher risk of subsequent injury if the recovery is not complete. So, that's important to make sure you educate your patients on that, because if they injure themselves and they don't allow themselves to heal completely, the likelihood is they will re-injure the same joint. So just make sure you give them that opportunity to know that it's really important to allow themselves to heal completely before they start activity that starts aggressive use on the joint again. It's really important to rule out any musculoskeletal injury. So make sure you're reviewing table 52.1 for assessment of musculoskeletal injury emergencies, because keep in mind, delayed recognition of certain diagnoses may lead to permanent disability or death. Okay, so that's why we talked about the Cauda-Equina syndrome. Once these diagnoses have been excluded, proceed with an orderly evaluation of other diagnostic possibilities. So remember, guys, you always want to rule out the worst case situations first, and then take it from there once you know that there's not an emergent situation going on. Much of the diagnoses is dependent on the patient's reporting of their symptoms. So you want to make sure you're getting a really accurate history, and you have a really good knowledge of the underlying anatomy and physiology of the musculoskeletal system that the patient is, presenting to or presenting with. A useful approach to the initial patient encounter is to determine whether the musculoskeletal complaint is, number one, acute or chronic in duration. Like, did the pain just start now, or has it been going on a long time? Is it articular or non-articular in origin? And by articular, we're talking about structures like the synovium, the synovial fluid, articular cartilage, intra-articular ligaments, joint capsule, and disorders of articular structures include are characterized by deep or diffuse pain, limited range of motion on active and passive movement, and swelling caused by the synovial proliferation, effusion, or bony enlargement. Also, you would hear crepitation, instability, locking, or deformity. These would be including an articular, it would be articular in origin, versus non-articular is more identified as extra-articular ligaments like tendons, bursae, muscle, fascia, bone, nerve, and overlying skin. Non-articular disorders are characterized by painful and active but not passive range of motion. Crepitus, instability or deformity is not likely to be associated with articular. Non-articular, that's more articular. Okay, so again, we're looking at, is the musculoskeletal complaint acute or chronic in duration? Is it articular or non-articular in origin? Is it inflammatory or non-inflammatory in origin or in nature? Do we have any swelling, or is there no swelling? And then the next thing we want to look at, is it localized or systemic in distribution? Okay, so if it's inflammatory, it may be infectious or idiopathic. And these are identified by the presence of erythema, warmth, pain, and swelling, versus systemic symptoms would include your fatigue, weight loss, morning stiffness, which is a big one in the musculoskeletal world, and fever. Or we could have laboratory evidence of inflammation with elevated ESR, CRP, anemia, or thrombocytosis. Non-inflammatory disorders tend to be related to trauma, like a meniscus tear, osteoarthritis, a neoplasm, or like fibromyalgia. Okay, so acute musculoskeletal injury encompasses many conditions and is characterized by acute pain of less than 6 weeks duration. Again, I'll repeat that. Acute musculoskeletal injury is less than 6 weeks duration. These injuries include damage to muscles, tendons, ligaments, nerves, and bursae. The most common types of injuries are your spasms, your strains, and your sprains, but we need to make sure we're able to differentiate between the three of those. So remember, your spasm is your persistent and painful reversible contraction of a striated muscle, versus your strain, which is a muscle injury caused by excessive tensile stress placed on a muscle that results in stiffness and decreased function, versus your sprain, which is a stretching or tearing of ligaments that occurs when a joint is forced beyond its natural anatomical range. Okay, so just again, make sure you're able to differentiate between a spasm versus a strain versus a sprain. And remember, differentiating between a strain and a sprain involves a careful patient history and physical examination, because patients who present with a sprain usually have some degree of swelling, pain, and disability. In severe sprains, deformity of the joint may be noted. Sprains can be classified as first degree, second degree, and third degree. So just make sure you're able to differentiate your first degree, second degree, and third degree sprains, okay? Paresthesias may be a result of the anatomical or mechanical peripheral nerve injuries, such as entrapment and compression neuropathies. These are most likely to occur at sites that are more susceptible to damage due to an increase in pressure and mechanical forces, such as entrapment or compression of the medial nerve at the wrist, such as like we see in carpal tunnel syndrome, right? So paresthesia, think carpal tunnel syndrome, okay? It could also include radial nerve of the forearm, or ulnar nerve at the elbow, or the peroneal nerve at the knee, okay? These are all areas of nerve compression that leads to paresthesia, okay? A characteristic set of signs and symptoms known as radiculopathy is caused by a compression or injury of spinal nerve roots due to spondylosis or degeneration of the vertebrae, or disc herniation. So we have the disc pressing down on that nerve, and it leads to something called radiculopathy. Now that is a diagnosis, guys. Radiculopathy is a diagnosis in of itself. It's not just a symptom, okay? So make sure you understand how to what radiculopathy is and how it presents. It's funny because when I first graduated and I realized, oh my God, like I can diagnose now, one of the first diagnoses that I made, documented, and coded was radiculopathy in one of my patients. So I'll never forget that moment, because it just, like, the light bulb went off finally, like, oh, I'm a nurse practitioner now, I can diagnose. What a concept. It was a pretty cool feeling. And I'm excited for you guys when you have that moment as well. But anyway, remember, radiculopathy is caused by compression. And the big thing is, how does it present? It presents with weakness, numbness, and tingling that typically occur along the distribution of the affected nerve root. So commonly you're going to see cervical nerve roots C5 to C8, lumbar nerve roots L3 to L5, and sacral nerve S1 is where you're going to see a lot of those symptoms stem from. Patients who present with paresthesia should undergo a detailed neurological assessment to determine whether sensory or motor deficits are present. An MRI is indicated when paresthesia is accompanied by motor or sensory deficit or hyporeflexia to rule out a spinal cord compression. And that's very important, guys. And here is where I really want to make sure you understand. So if there's any change in the bowel or bladder function suddenly, that's also associated with any kind of paresthesia, we call that Cauda equina syndrome, okay? And again, that constitutes an emergency and needs immediate assessment by a specialist. So keep in mind, if a patient comes in, they're complaining of pain, numbness, tingling, and all of a sudden they're saying that they don't have control of their bowel and bladder, ding, 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 emergency, call an ambulance, get the patient to the emergency room, have them admitted, okay? And they need to be immediately assessed, okay? Then we have our myofascial pain, which is caused by the development of trigger points within a muscle. So in terms of examining for any of these musculoskeletal complaints, the examiner should begin by inspecting the affected part, observing for side-to-side symmetry. The patient must be undressed and draped so that the visual inspection can be done. And then the thing I wanted to point out is that the uninvolved side should be examined initially by the nurse. When you're examining your patient who's coming in with musculoskeletal complaints, you want to assess the uninvolved or the non-affected side first, and then compare it with the side of the complaint or of the involved side. So first, you're going to assess the uninvolved side, and then you're going to assess the involved side, and you're going to compare the two. The painful part of the area should be examined last, okay? So when we focus on our history of our musculoskeletal problems, the questions we want to be asking are, how did you injure yourself? Have you injured yourself? Describe exactly how the injury occurred. When did the injury occur? Did you hear any noise or sound as the injury occurred? Meaning, did we hear anything break or pop? Do we hear any crunching? If so, describe the sound. Where does it hurt? Does the pain radiate? Is it localized or diffuse? Do you have numbness or tingling? Is there a loss of function? Remember, we're looking for our worst case scenario. Worst case scenario especially when it comes to back stuff or nerve stuff, is your Cauda equina syndrome. So again, when is there loss of function? Loss of function could be like you can't use the joint, you can't use your fingers, you can't walk on your foot, or you've lost your ability to control your bowel and bladder. That would be loss of function, okay? Is there swelling, and when did the pain first occur? What relieves it? What makes it worse? What time of day does it occur? Does the pain awaken you at night? Remember, guys, this is your basic assessment. Hopefully you remember this from your health assessment course. You're going to look at your old CART, onset, location, duration, basic stuff, right? Is there joint stiffness? Does the activity make it worse or better? Do you have any other symptoms, fever, rash, any fatigue? Have you been traveling or camping? Remember, we want to consider, did this patient get bit by a tick? Because remember, joint pain is associated with tick bites, right? Have you recently been immunized? Okay, immunizations can cause joint pain, and maybe even something as severe as paresthesia. Have you recently been treated with antibiotics? Are we having an allergic systemic reaction to the antibiotic? Do you have a history of upper respiratory infections, systemic transmitted diseases, chronic diseases? We're looking for any systemic symptoms here, right? Or any kind of differentials that would be systemic in nature. Were you ever treated with steroids? We want to know if they've had any reactions, because if there are some inflammatory issues or pain, we may need to treat with steroids. So we want to make sure this patient didn't have a bad reaction prior. Describe your daily activities. We want to know what they're doing at work, what hobbies they do. Do they play any sports? Do they exercise? When they do exercise, what are they exercising on? Or, you don't know how many patients I've seen who come in who are exercising on an elliptical, on a treadmill, with knee pain, joint pain, hip pain. Those consistent movements on those joints, on those machines, can really do damage. So people have to be very conscientious of not overdoing it on those machines and in the gym. So just make sure you're educating your patients on that. In terms of people playing tennis elbow is very, very common. So just make sure you're asking again, what daily activities, hobbies, what do they do for exercise? What do they do for work? Are they in construction? Any injuries on the job? Any history of injuries? Any surgeries? Remember, you're doing a really thorough assessment to figure out your differentials here. In terms of your wrist and hand pain, you're going to definitely want to make sure you're reviewing your Allen's tests, Phelan's tests, Tinel's signs, Finkelstein's test. All of those are in your book. Just make sure you're reviewing those tests and the purpose of them, as well as how you assess them. You're also going to want to make sure you do range of motion of the fingers and wrists and how you would assess that. Here in the book, they talk about this therapeutic procedure of removing rings. I've never had to do this, thankfully. I haven't ever seen this done either. I mean, I've seen rings removed. To be honest with you, a lot of the times people will take off rings very easily with Windex, believe it or not. So before you go through the pain of doing this procedure, I would suggest try spraying some Windex on that area and just seeing if that helps. Okay, so then we have spinal disorders. You're looking at your herniated lumbar disc. Remember, these most commonly occur at L4, L5, L5 to S1 levels, okay? You're gonna wanna review the symptoms that are associated with each level so that you know how to pinpoint which level is being affected, which disc, so that you know how to treat and diagnose your patients. We have lumbar spinal stenosis. Remember, again, please review this. Cauda-Equina syndrome is an emergency, and it's not very common, but when it happens, you need to make sure you get this patient treated immediately. Vertebral fractures are the most commonly associated with osteoporosis. So when you have your female patients or your patients with osteoporosis, you're going to want to do a lot of education on prevention, fall prevention, and how to treat this so for daily management to prevent it from getting worse. Then the book got into your soft tissue disorders, trigger finger, ganglion cysts within your hand and wrist disorders. Again, make sure you're reviewing your range of motion with your fingers so that you know how to assess that in your patients. Hip disorders and ankle sprains are a big thing. Hip pain is discomfort within or around the hip, obviously. And keep in mind, your hip joint is the largest in the body, and it is subject to stress from ambulation and weight bearing. It may suffer trauma and chronic mechanical stress, especially in those patients who are athletes and who are, constantly on their legs or just using those hip joints, especially like I mentioned before, on those machines in the gyms. They can really, really aggravate any kind of hip disorders. Pain in and around the hip can often be felt in the groin or the buttock, and it can be referred also to the thigh or the knee. Conversely, pain may be referred to the hip if irritation to the femoral, sciatic, or obturator nerve roots occurs. These may be the result of herniation of the lumbar disc from spinal stenosis, a retroperitoneal tumor, or a femoral hernia. Again, the history should ascertain if the pain is focal, as in bursitis, or diffuse, as in synovitis. The presence of stiffness should raise the suspicion of a degenerative disease. We want to inquire about trauma or involvement of other joints in terms of pain or problems, infection, fever, and relation of pain to activity. When you're assessing the hip, you want to first assess the position at rest, because fracture of the femoral head results in external rotation and flexion, and an internally rotate and shorten leg may be a posterior dislocation. These patients should not have the hip moved until radiographic studies have ruled out fracture or dislocation, and performing palpation of the joint allows recognition of focal tenderness and swelling. In terms of ankle sprains, obviously it's an ankle injury that results in ligamental damage. You want to look at table 52.9, those special tests specifically for your assessing ankle ligaments. You want to make sure you differentiate your anterior drawer test and your varus stress test. Again, osteoarthritis and osteoporosis. Risk factors for your osteoarthritis include your age, genetics, and of course, obesity. The typical joints affected in OA are your hands, your knees, and your hips. And management includes physical therapy, surgical consultation, Tylenol, NSAIDs, corticosteroids, and viscosupplementation. Your osteoporosis, keep in mind your risk factors here includes age, tobacco use, eating disorders, family history, excessive alcohol intake, and sedentary lifestyle. Here's where I was talking about in terms of management with these patients, fractures are very big in osteoarthritis, osteoporosis. So the big thing you want to educate these patients on is your weight bearing exercises. It's really important if they can do like weight bearing exercises with, low, like 5 to 8 pound weights, like 3 or 4 times a week. It really will help build their bone density, and it really, really helps them from losing bone mass. So really important to educate your elderly patients, geriatric patients on weight bearing exercises to prevent osteoarthritis from worsening. Also, big thing in terms of home safety, you want to make sure you're definitely educating on fall prevention with these patients with OA and osteoporosis. If you're finding that these particular patients are having a lot of falls at home or have any falls, you may want to definitely consider making a referral for these patients for home care services, for some physical therapy, occupational therapy at home, as well as safety, a safety assessment from their local visiting nurse service, just to make sure that they have all the resources at home that they can have. The physical therapist will go into the home and make sure the home is safe, as well as order equipment for these patients to make sure they have any kind of assistive devices to prevent falls. We could also get a social worker at the patient's home to have different resources set up for the patient, whether it's the safety alert system in the home, the fall preventer, what is it called? Help I've Fallen. Just any of those types of resources at home just to prevent those falls. Okay, definitely review page 795. You have your musculoskeletal complaint algorithm. These are my favorite for helping you differentiate your diagnoses and really fine tune, your history and physical exam, because this will really give you a clear picture as to what to ask and what to do next. Okay, we definitely want to talk about, obviously, your sports physicals. Please see your module and review the American Heart Association's policy and guidance on identifying abnormalities that could provoke to disease progression on sudden death. Under there, also, I uploaded your pre-participation cardiovascular screening of young competitive athletes policy guidance. Keep in mind, sudden cardiac death represents a public health risk to competitive and non-competitive youth, high school, college, recreational, and professional athletes in the United States. So it is the leading non-traumatic cause of death among young athletes. So SCD, or sudden cardiac death, is the leading non-traumatic cause of death among young athletes. That's why these pre-screening physicals are so important. And the other big thing I want to mention to you is, because it's sudden cardiac death that we're trying to prevent, one of the things you're doing is your cardiovascular assessment within these physicals. So please make sure you're reviewing your irregular heart sounds or your heart murmurs or any abnormal heart sounds, because as long as you're listening to these students' hearts or these athletes' hearts when you're doing these screenings, You're listening for normal heart sounds as well as anything abnormal. And as soon as you hear anything abnormal, that's when you need to make your referrals and you're holding off on any kind of clearance. So if you don't know what abnormal heart sounds are, you're not going to do any justice to these physicals. So make sure you're reviewing your heart sounds, abnormal and normal, prior to doing any of these physicals to make sure you're very clear on what you're listening for. The precise incidence of sudden cardiac death among high school athletes, for example, is unknown, but it estimates it ranges from 1 in 23,000 to 1 in 300,000 of athletes can be caused by a variety of cardiovascular diseases, but it is most commonly associated with congenital or acquired malformations. Any intense athletic activity can trigger sudden cardiac death or disease progression in these susceptible individuals, and that's why they made all of these recommendations. So the American Heart Association recommends the following with regards to pre-participation screening of young competitive athletes. Number one, they're saying it should happen, the pre-screening should happen annually and consists of a targeted personal history, family history, and physical exam. The physical exam includes 14 key pre-screening elements, which your textbook definitely goes over considerably, and we'll talk about in the next few slides. At this time, the American Heart Association does not recommend the use of tests like a 12-lead EKG or echo in these particular pre-participation screening programs. Instead, though, they do recommend these tests should be used as a follow-up if during your initial pre-screening, the practitioner heard an abnormal heart sound. Obviously, then you would make the recommendation that they need to have an EKG prior to being allowed clearance for their sports. So because of these AHA guidelines, national standards have been developed to ensure a systematic, uniform, evidence-guided participation cardiovascular screening of these high school athletes. So these uploaded physical forms that I put in your module, they're pretty consistent across the board, across all school districts. You guys are a lot of you are parents. You may have seen these forms for your own high school students or even middle school. We have these forms filled out. The school nurse usually mails them out at the beginning of the school year, and it's the parent's responsibility to fill it out, or the student fills it out. Okay, so policies, programs, training, and continuing education that increase provider knowledge of pre-screening guidelines should be implemented. So in our particular district, when I was running these programs in our school district for our middle school and high school, we did have quite a thorough education for all of the practitioners in the health offices who were going to be assisting in these sports physicals. So I had an LPN, I had 2 aides. They all helped in these gathering all this information in these forms, and I had to review with them extensively what was needed in these forms, what they needed to make sure was visibly written, and if they didn't see it, they needed to bring it to my attention before we put it in the clear pile, so to speak. Okay. So yeah, a lot of education goes into this, and I've listed these resources in terms of the American Heart Association. Any of the resources that I post, guys, are specifically so you know where to go to find these particular resources when the time comes. If you did have to, do a sports physical, or if the season was up, here's where I go to make sure I have all of the most updated evidence-based practice, so that when we standardize our office or your primary care practice, you have everything you need that is going to make sure you're giving the best practice and you're meeting guidelines. Okay, so the purpose of sports physicals, also known as the pre-participation physical, so keep that in mind. The sports physical is also known as the pre-participation physical. It is to promote safe sports participation by identifying high-risk situations. Sometimes, again, these are called PPE. These exams are not meant to exclude athletes from participation. These exams are generally a formal requirement that are done annually before participation in junior high, high school, and college or professional sports. Objectives of these sports physicals are listed in your table in 76.1 in your box. But a 2014 study documented that the requirements for pre-participation physical evaluations use and the content of the evaluations vary and are determined by each state individually. But however, to ensure comprehensive and consistent screenings, the American Heart Association has given us like these standardized guidelines for these particular screening tools. So remember, it's done yearly, it's required yearly, and it's required prior to playing any types of sports. Okay, so there's different ways of running these exams in terms of sports physical. So it could be an office-based exam where the student or the athlete goes directly to their doctor and gets their exam, or their primary care provider, right? And it's just done, right there as just your regular exam. It is more expensive, although it's a yearly physical, and most insurance companies pay for that. So just keep that in mind. A lot of the times what will happen is the student will just bring in their sports pre-participation sports physical form with them when they're coming in for their regular physical, and you kind of fill them out at the same time. The other option for this exam that the book calls the assembly line exam is basically a single provider exam and several athletes, one after the other. We had this particular type of exam in our school district where we had our medical director, doctor, come in, and we put all the students in a line after we did the pre-clearance with their forms. It was myself and the LPN that was assisting me. We read through all their forms, and then we had the doctor go in and see this doctor specifically for the sports physical. It is cheaper, obviously, it's quicker because it's done in the school, so usually the school district pays for it. But again, there are drawbacks to this because, of course, it does lack individual attention. It increases the risk that insufficient medical history is taken, and it lacks continuity. All of that is absolutely correct. I would not recommend that you do it this way unless it's absolutely necessary. Unfortunately, the schools set this up because they really want to make sure these students are getting assessed. But I am very, very, I didn't like this method at all. I did not think it was thorough. I didn't like that the doctor literally took 3 to 5 minutes per student. I don't think that's a thorough assessment for anybody, especially, young students who you don't know these students. You're just meeting them for the first time. I didn't agree with it, but it is something that happens, and it is an option. Okay. You just want to be very careful with that, especially if it's, if you're going quickly and there's any kind of question, especially what I usually did in that particular instance, I really focused on the student's history. If there was any concern with asthma or any kind of back history that the student had, or had previously had any kind of concussions, immediately I pulled them out of the assembly line exam, quote unquote, and instructed them that they're going to need to be assessed more thoroughly by their own physician for clearance. And that's kind of how I handled that in that particular instance. Then there's the station exam where multiple examiners do different parts of the exams. We kind of had a combination of the assembly line and station exams kind of combined. We did it kind of that way. Again, it saves time, it's cost efficient, allows the use of providers with specialized expertise. It can be disorganized. It can be, if you're not careful and there's too many people involved or too many stations, so to speak. There's potential for inadequate integration of findings. It's impersonal, lacks privacy, and may feel rushed. That is correct across the board, both for assembly line and station exams. But again, you set it up what works for your particular population. In our assembly line exam, so to speak, with our particular student body of 1,800 students, a lot of them, like I had mentioned before, I didn't even let them go through the assembly line because a lot of them weren't up to date on their immunization. So right there, I shut it down. I said, nope, you got to get to your doctor, get up to date with your immunizations, and you can take it from there. Okay, components of a sports physical. One of the biggest things is your history. It gives the provider the most of the information needed to make an informed decision. It should be completed by the athlete and parent prior to the examination. So they're filling out and answering quite a few questions about their history. And that does need to be handwritten and filled out by the patient or the parent, or by the athlete or the parent prior to the exam. You're reading that history, and from that history, you can shut things down immediately. And by shutting it down, I mean saying, no, I'm not going to clear you. There's got to be this, and this has to be done before we even get to the physical exam. Okay. There's going to be the baseline things that are included in your history include your medical conditions and diseases, any past history of surgeries, hospitalizations, medications. Big thing. I want to know what this student is taking. And a lot of the times I already know what the student is taking, because if they are on any prescribed meds, they're getting them in the school, they're coming to the health office to get them. So, the nurse is giving them to us. So we have already that documentation. We want to make sure we're aware of any allergies, specifically any allergies that require an EpiPen, anaphylaxis allergies. We had a lot of students in our school who had peanut allergies and insect allergies. So those students, if you're playing sports, guess what? You're not cleared for sports unless I have an EpiPen in the cabinet ready to go with a prescription for you. Okay, these are things to keep in mind before you clear these athletes. They need to have an EpiPen on the field. If a student has a severe anaphylactic allergy and they don't have an EpiPen on the field and they've been cleared for sports, guess who that falls on? Okay, so again, these are all things you need to consider when you're talking about sports physicals and clearing students for sports. Again, immunization status. No student should be cleared for sports if their immunizations are not up to par. That's very basic. That should be immediately handled, okay? Menstrual history, psychosocial history, these are things you're gonna wanna actually ascertain because your menstrual history is also going to give you clues into your Tanner staging. Remember we talked about Tanner staging in terms of puberty. The student is staged for Tanner because depending on their Tanner stage, it will depend on what level of sports they can play, what they're eligible to play. Okay, so again, additional information to consider when it comes to looking at your students or athletes' medical history and conditions and whether or not you're going to clear them or not, because all of these things listed here would definitely make me question whether I am going to clear the student or just making sure that they have certain things in place for them. For instance, for the asthma, I'm not clearing the student to play unless, I make sure they have a prescription for a rescue inhaler while, available to them. And the school needs to be aware that they can only play as long as that inhaler is available, right? These are things to consider, right? So asthma is a common cause of exertional chest pain in young athletes and can be a sign of left ventricular outflow tract obstruction or coronary artery anomalies. If this is a new condition, obviously the athlete should be referred to a pulmonologist, okay? Has the student had any concussions recently? Because disqualification for athletes with a history of frequent or severe concussions is a thing. It is controversial, but it is something that needs to be taken into consideration. As a provider, you need to determine the number of concussions the athlete has had, their duration, the frequency, the recovery time, and the risk factors, meaning why is this happening? What sports is this student playing? Okay. Athletes with signs and symptoms of concussion would include brief loss of consciousness after the injury, memory problems, confusion, drowsiness, feeling sluggish, dizziness, double vision, blurred vision, headache, vomiting, irritability, insomnia, loss of concentration and memory, noise and light sensitivity. All of these, if any of these symptoms that your athlete is exhibiting, they should not be cleared for participation until all of those symptoms have resolved. You're also going to want to do formal balance testing, which is usually done by the athletic department. If the student or the athlete ends up having a concussion during sports, they do a lot of balance testing, such as the balance air scoring system, and also some neuropsychologic testing, which needs to be done before sports participation. And when head injury occurs, they need to be cleared before they are allowed to play again. Dyspnea on exertions and becoming easily fatigued may simply represent poor conditioning. However, primary pulmonary hypertension, profound anemia, exercise-induced asthma, or any underlying cardiovascular disorder should be suspected. And they should be referred for a workup before they are cleared for participation. Okay, especially your athletes who are obese, who want to suddenly start playing sports. They need to be cleared before they are allowed to play, because you don't want something to just happen all of a sudden on the field that you missed just because you thought they were poorly conditioned. Eating disorders, psychiatric disorders, and abuse. You want to be very careful in your aesthetic sports with these types of disorders, like your figure skating, dance, cheerleading, diving. These athletes are all at very high risk for eating disorders. Athletes with untreated mental illness should receive treatment and be stabilized before resuming athletic participation. Okay, so if you're having these athletes come in and you're doing a physical assessment and finding that their BMI is too low, why? Why is their BMI so low? Do they have an eating disorder? Are they any mental illness? Like, these are things that need to be followed up. It's interesting how many things you discover during your pre-participation exams or your sports physicals. It's very interesting how many things are not caught in regular physicals that you suddenly notice in a sports physical. You're definitely going to want to do your family history. Of course, if there's any family history of premature sudden death, we're going to want to go ahead and get this student an EKG or an echo, just to make sure that they don't have any underlying cardiovascular disease. You may even want to consider referring the athlete to a cardiologist if they do have a family history of premature sudden death. Any hematological disorders like bleeding disorders such as hemophilia or von Willebrand disease, they should be restricted from contact or collision sports. That's a very important point, guys. Just make sure, I'll show you on another slide, but make sure you are very clear on what contact versus collision sports versus non-contact sports are, because you can restrict them from certain athletes or students from playing certain types of sports depending on what's going on with them versus non-contact sports that they could be okay to play. Athletes with sickle cell disease are limited to low intensity activities. Those with sickle cell trait may participate in all activities. However, elevation, dehydration, and illness are risk factors that may cause exertional sickling. So, keep that in mind, guys. We want to try to limit the physical stress on sickle cell patients. But a lot of these students, they really want to play because they're young, they're at school, you got to kind of give a little, but you watch them. I used to have a file specifically for my high-risk athletes or high-risk students that had certain historical things, risk factors. I kept their files separate. I kept a list of them separate. So if I got any calls or if they were sent down to the health office, with whatever issues, whether they got hurt during gym or hurt during playing sports or whatever, I could quickly look at their file just to see, if there was anything I needed to make sure I was flagging or looking at, in particular, these particular athletes. And these particular athletes that have these hematological disorders or any kind of concern that you want to make sure you're monitoring as these students are playing or athletes are playing, you also want to give a heads up to the coaches and the head athletic directors. Okay, they need to be aware as well. They work actually very closely with the school nurses to make sure that everybody's on the same page in terms of like what EpiPens need to be on the field. Do they have an AED on the field? Like things like that are very much in tune with your sports physicals and your practitioners involved with managing these athletes. Obviously, if we have any palpitations, we need to make sure that those students are cleared and further evaluation is done prior to them being cleared. Seizures, athletes with well-controlled seizures can participate in most sports, except those that could be fatal, such as skydiving, hang gliding, and scuba diving. We didn't have that in our school district, so that was never an issue. Syncope and pre-syncope, they should not athletes with exercises related syncope or pre-syncope should not be able to participate in sports until they're cleared by a cardiologist. That could be very dangerous, obviously. So again, just make sure these students are cleared with any of these particular diagnoses, that they get further follow-up and workups before they are cleared for sports. Okay, so components of your sports physical. You want to look at your table 76.3, your focus points. These are the things you want to look for and assess for throughout your physical exam. So obviously, yes, you're looking at your height and weight, but not only are you looking at your height and weight and BMI, you're checking for anorexia, you're looking for morbid obesity. We want to just look for certain particular things that we're going to give us red flags that are going to say, hey, we're not clearing the student until we get further workups. So we're looking at our head, ears, eyes, nose, and throat. For visual acuity, we want to make sure we don't have any detached retinas or monocular vision. You also want to ask about concussions when you're assessing the head, ear, nose, and throats. Pulses, you're looking for irregular rhythms. You're looking at all your peripheral pulses. You're auscultating all 4 valves of the heart. If we needed follow-up, we're going to look at an EKG for any irregularity. We want to make sure if they have hypertension, that it is controlled prior to sports participation, especially in your obese patient athletes. I did have a few students that I had to hold off on them playing because it turned out during their exam that they were hypertensive, and they ended up going to their physician and they had to get on a diet and blah, blah, blah. But these things, again, the students and the parents are like, what do you mean they can't participate? What do you mean his blood pressure is high? and you have to do a lot of education and really just emphasize, no, it's dangerous, and explain to them why. And great times to do education and just just letting them know on prevention and risk factors, on how they can modify these modifiable risk factors. In terms of the cardiovascular system, again, this is where we're looking at the American College of Cardiology and the American Heart Association. Look in your module, look at those guidelines that I uploaded. You're looking at Marfan syndromes. You're looking, also make sure you're looking at the skin. You want to look for any contagious diseases, tinea, boils, impetigo, herpes. Okay, we don't want this stuff getting into gyms and locker rooms, right? Remember, keep in mind, guys, there's you've got your athletes that are wrestling, they're touching each other. You want to make sure you're not putting anybody else at risk for any kind of infectious thing. Again, so we went through all this. You definitely look for hernias as well, guys. That's something that you can always diagnose. Your respiratory system, your respiratory rate should be measured both anteriorly and posteriorly. Again, uncontrolled asthma and exercise-induced deoxygenation are reasons to restrict contact sport participation. In terms of your musculoskeletal system, you want to look at flexibility, gait, muscle performance, any joint laxicity, and strength for our key components for evaluation. So you're looking at joint laxity, strength, muscle performance, gait, and flexibility. Any asymmetry of the joint muscles or range of motion that's limited, those things need to be further assessed. The goal of this component of the sports physical is really to identify risks of and prevent injury, all right? So again, we're talking about unrestricted clearance after completion of further evaluation or rehab, or disqualification or no clearance for certain types of sports or for all sports. So in terms of unrestricted clearance, it indicates that the athlete is cleared for all sports and all levels of participation. If the athlete has a health issue that needs evaluation or treatment, or has suspicious signs or symptoms for further workup, or they need, to get caught up on their immunizations, they need to wait on their clearance, and clearance will be done after completion of further evaluation or rehabilitation. And then we have disqualification. Examples of disqualification that can limit participation are shown in table 76.4. So just make sure you review that. And again, remember, the Committee on Sports Medicine has developed a list of recommendations for participation in that table. Also, review table 76.1, sports by level of contact. So remember, your contact sports include field hockey, football, martial arts, rodeo, boxing, and lacrosse. Those are all high impact, high contact sports, okay? Then we have collision sports, which are much more, you're gonna be knocking into each other, right? So that would include your soccer, wrestling, ice hockey, rugby, baseball, basketball. Those are your collision sports where you have a risk of colliding into each other, right? And then you have your non-contact sports, which include aerobics, track, fencing. I don't really know if I feel like fencing is non-contact, but whatever. Swimming, running, weightlifting, archery, golf, tennis, even tennis. That's, I don't know about non-contact. Crew and riflery. So those are technically considered your non-contact, okay? But, even though, like, let's say I was just saying, fencing and tennis, they're non-contact, but when you consider what the risks are of these particular sports in terms of getting hit by a ball with tennis, or even when they're fencing, you could get hit. Like, that's something you want to take into consideration depending on what's going on with your athlete, all right? Or whatever their history is, or whatever concerns you may have for them. You want to think about risks and what the potential of risk factors are for these students. Like, how dangerous is it? I had one student in middle school who was on his second kidney transplant, who wanted to play soccer so badly. And I had to go through a lot of hoops to, because everybody was wanted him to play. I was not comfortable with it. So I went all the way to his, to the hospital, to his transplant team to make sure that, and have them write a letter that they were comfortable with him playing soccer. That's how intense it was, because it was and not to mention, he was very small for his age. He was very poor nutritionally. He just didn't eat much. He was a great kid and he had a lot of energy, but he was very high risk. So actually the transplant team agreed after speaking with the student and the mother and the family that they all understood the risks, understood the liability, but they were all in agreement that they wanted him to place, contact. So they wrote a letter clearing him and we were all in agreement. But again, I watched him like a hawk. Okay, on to palliative care and pain management, chapter 78. Here we go. Talking about pain management, I put in this little picture of the CDC because I wanted you to understand the level of how much the CDC guides the guidelines for prescribing opioids, especially since the recent issues with the opioid epidemic. So please make sure you're looking in your module. I uploaded quite a few resources from the CDC for you guys to review and just be aware of that exists, including that app. So I wanted to make sure you got that. Palliative care focuses primarily on anticipating and preventing, diagnosing, and treating symptoms experienced by patients with serious or life-threatening illnesses and helping patients and their families make medically important decisions. Helping patients and their families understand the nature of illness and prognosis is a crucial aspect of palliative care near the end of life. Receiving a diagnosis of life-threatening disease can be a frightening experience for the patient and family, and fear of potential suffering and pain, as well as the fear of loss of control, relationships, and existence itself are some of the issues that confront the patient. Listen, guys, dying is scary. Not only is it painful, it is very, very scary. And it's terrifying, but it is the one thing that we as human beings all have in common, and it will happen to all of us. Not one of us will, not have this happen. So the idea is, from a humanity standpoint, as practitioners, we want to make that dying process as comfortable as possible, right? And again, we want to make sure we're differentiating palliative care versus hospice care, but they do kind of go hand in hand. And usually when I would refer a patient for palliative care, it was usually the first door on their way to hospice care. All care providers and clinicians can improve the recognition and management of the distress related to a terminal diagnosis, okay? According to the National Consensus Project for Quality Palliative Care on palliative care, the goal of palliative care is to prevent and relieve suffering and to support the best possible quality of life for patients and their family, regardless of the stage of the disease or the need for other therapies. It can be delivered concurrently with life-prolonging therapies or as the main focus of care. So that's really palliative care, guys. It can be delivered while you're still trying to prolong life. So while you're still getting that chemo, getting that radiation, getting that treatment, you're still getting that palliative care to kind of deal with all the symptoms of this disease process. So the National Consensus Project for Quality Palliative Care has provided recommendations for care domains in palliative care. So I just wanted to review these 5 areas that lead to quality palliative care. So the 5 areas are delivery of person-centered and family-focused care, which is very easy to remember. So we want to make sure we're delivering, patient-centered care, family-centered care. Client and patient communication and advanced care planning. So this is where you really have to have a heart-to-heart conversation with your patient and their family and discuss that advanced care planning and what their wants are in terms of advanced directives. The third one is professional education and development. So there's a lot to learn about palliative care and pain management. In of itself is its own specialty. I had the great honor and just experience of, during my clinical rotations, when I was in grad school, my preceptor was the director of pain management at Danbury Hospital, and I worked with her for a semester, and boy, what an experience. She was wonderful. She was a wonderful educator, but on top of it, I had no idea the level of professionalism and thought process that goes behind pain management and the pressure that's also with it. Not only did I follow her, I also was able to follow the palliative care team around for a semester as well within Danbury Hospital. Also such a wonderful resource. I don't know if any of you could reach out to them for your preceptorships, but I would highly advise the palliative care team over at Danbury Hospital. Unfortunately, the pain management director is no longer there. She moved on to a different state, but they have a wonderful program at Danbury Hospital, just so you guys know. So the World Health Organization defines the patient-centered approach that improves the quality of life of patients and families when they're experiencing life-threatening illnesses and pertaining to palliative care. So just make sure you're clear on the WHO definition. The principles of palliative care, of course, focus on anticipating, preventing, diagnosing, and treating symptoms, especially in relation to pain, and helping patients and their families make medically important decisions and understand the nature and illness and the prognosis. The basic goal of palliative care is to prevent and relieve suffering, to allow the quality of life to be good until the end. That's basically what it comes down to. Palliative care and hospice care, we want to understand the differences between palliative versus hospice care, because most of the time you're going to hear people use those terms interchangeably. Both provide supportive medical, social, emotional, and spiritual services to patients and their caregivers, and both services rely on the combined knowledge and skill of interdisciplinary teams and professionals. But hospice care provides care to patients at the end of life, while palliative care provides comfort care and a support system to both the family and patient from the time of diagnosis until death, and encompasses end-of-life care. So both palliative care and hospice care provide that supportive medical, social, emotional, and spiritual service, but they do have those key differences. Again, hospice tends to be more focused to the end of life, versus palliative care can be from the beginning till the end, okay? Primary practitioners who provide care to chronically ill patients with terminal conditions are expected to incorporate the basic elements of palliative care into their practice, regardless of setting. Okay, guys, so that is a basic standard of practice. And most of the time, it is covered by insurance. So just so you know that. Hospice care includes palliative care. However, a referral from a physician is required to initiate hospice care. Hospice care is overseen by a team of hospice professionals in the home and occasionally in a hospital or a hospice place location. A hospice patient receiving hospice care must be considered terminally ill or have a diagnosis of dying within 6 months, or less. The likelihood is they will die. I mean, as a practitioner, you obviously can't officially say the patient's going to be dead in 6 months, but what you're saying is that the likelihood is, because of the nature and the diagnosis of the diagnoses, the likelihood is based on all the diagnostics and the assessment of the patient that due to their diagnoses, the likelihood is they will be passing on within the next 6 months. So if they have 6 months or less to live, then they're likely going to be accepted onto hospice, as well as they have decided that they're no longer going to be doing anything active to keep themselves alive. Most hospice costs are covered through insurance providers such as Medicare. However, it is important to check with each hospice program, as some can vary in cost and reimbursement. Some hospice programs offer subsidized care for the economically disadvantaged, so just keep that in mind. There's a need for palliative care. Like I said, it is its own, specialty. There's a rapid growth for need for palliative care providers. So if any of you are interested in working in palliative care, I think it's a wonderful specialty. Traditionally, it's more focused on people with cancer. So if you have an oncology background, that obviously is very helpful. The care is ideally delivered by an interdisciplinary team that focuses on the needs of the patient and family. So it's interesting, they say that it's very important to realize that the palliative care team at Danbury, when I was following them around, it really was a team. It wasn't just the palliative care nurse practitioner. It was also the social worker. It was also, when we sat in rounds, we would sit in rounds every morning before we, we would sit in rounds. Not rounds, I'm sorry, we would sit in our pre-conference before rounds every time every day before rounds. And in that conference would be all the palliative care nurse practitioners, the head of the palliative care department, the head physician, the head spiritual minister within the hospital, and then there was a couple of clergymen that would also sit in. We also had a holistic nurse practitioner that would sit in because we would make referrals for any kind of holistic care for any of our palliative care patients that we thought would benefit from it, whether that was Reiki or any kind of aromatherapy, gentle healing touch. We would refer for that, but we would all sit in a conference before rounds and just really work together as a team to bring all of these services to these particular patients. So just keep in mind, palliative care is definitely an interdisciplinary team approach. Okay, so palliative care is part of a primary care practice. Again, in terms of, we want to try to get the palliative care into community health centers as well as primary care offices. And the foundation of the California Healthcare Foundation, they're the ones who are advocating for it, and they have actually found opportunities as well as challenges for this mission. And I just wanted to go over those with you because I thought it was interesting. So some of the challenges they found about getting palliative care in your primary care practices is that there's not enough time to work with patients and families on goals of care and advanced directives, which is true. But I mean, if you specifically scheduled an appointment or a follow-up visit with a patient specifically to go over this, I think that could kind of go over, help overcome that challenge. It's an added responsibility in a busy primary care practice. Of course it is, but I mean, it's part of your patient's care. So you kind of have to figure it out, right? Make it work. There's no real viable payment mechanism for reimbursement. So again, maybe if you incorporated it into another follow-up visit, somehow you could make that, billable at some level. Direct deferring resources required by different patients. So yes, there are a lot of resources that, every patient there's a lot of different resources that patients may need. What you may want to do is have somebody specifically set up an kind of an area in your practice that has all these different areas of resources that you could refer to, like pamphlets, just different, whether it's pamphlets or brochures or business cards to specific different resources that you can just kind of guide your patient with. And then of course, there's the lack of the primary care provider's understanding of palliative care. But again, there's so many resources, so many webinars, like don't let yourself be uneducated in any area, guys. There's so many free resources out there that will guide you in terms of palliative care or any kind of care for that matter. In terms of opportunities and growth in incorporating palliative care in your primary care practice, it obviously provides an important service to the community. You're working with long-term patients whose history, family, and personal wishes are already known and understood. So isn't it wonderful to be able to go to the doctor you've been seeing all these years, who unfortunately, now your patient is dying, but at least you're with them and you're, at least you're helping them through this process and you're giving them a full, a holistic care here. I mean, and this patient and their history and their family. So it only makes sense that you would be helping them in this part of their journey as well. You're being on the cutting edge of an expanding concept for helping patients with long-term illnesses. So yeah, you're helping develop research and giving, kind of gathering information for long-term research. Keep in mind the need for palliative care will continue to grow as the US population ages, right? And providing palliative care in the primary care setting by creating teams led by nurse practitioners seems to be the ideal method to promote end-of-life care, reduce the cost of unnecessary aggressive care, and improve the quality of life of adults experiencing life-threatening illnesses and provide comfort, compassion, and for patients and their families, guys. So in terms of standards for palliative care, the Joint Commission has their own revision of standards from 2015. Excuse me, just see table 78.2. It's pretty basic standards. Like standard 1 is patient and families know how to access and use the program's care, treatments, and services. Standard 2, the palliative care program communicates with patients and families and involves them in decision-making. Very basic standards, but these are the things you need to consider if you do decide you're going to incorporate a palliative care type program into your practice. Okay, you need to understand that the Joint Commission has already set up standards for a palliative care program requirements. Okay, so initiating palliative care. So again, the most important aspect of communication at this time is to let patients know that they are being heard and that their perspective is important. Open-ended questions can be asked to explore the need for palliative care, such as saying, hi, Mr. Smith, what is your understanding of where things stand now with your illness? as you think about your illness, what is the best and the worst that you're thinking about might happen? What has been the most difficult about this illness for you? What are your hopes, expectations, and fears for the future? As you think about the future, what is the most important thing to you? What matters most to you? And do you have strong religious or spiritual beliefs? If so, whom do you talk to about spiritual matters? Would you like this person to be involved in your decision making at this time? And another question would be, do you have any additional concerns? So again, you're just feeling them out. You're just kind of figuring out, where is this person at? What is their understanding of what's going on? Are they being realistic? Are they ready? Are they open to any kind of help? You don't push, you don't judge, you just ask and let them give you whatever information they're willing to give you, and you just take it from there. Okay. Again, you're just trying to make this an easy process for them. You're not trying to antagonize them or make it more stressful. Okay, aspects of palliative care. So total pain is defined as the sum of the patient's physical, psychological, social, and spiritual pain, and that's a very central concept to palliative care. Pain is not just the physical piece, it's the psychological, the social, and the spiritual piece that comes with pain. Again, remember, dying in of itself is very painful. It's painful physically, it's painful spiritually, it's painful socially. Like, there's a lot of pain involved. So we want to try to deal with all aspects of their pain, right? Optimal physical pain relief is not possible unless all elements of total pain are addressed. And again, managing total pain requires a team approach to determine the meaning of the pain to the patient, the extent of the physical pain, the fear elicited by the physical pain. These are all things to consider when you're talking about pain. Increases in physical pain are often associated with dying by the patient and family, and can increase depression, distress, and muscular tension in the body. Until all of these issues are addressed, the patient's total pain may remain uncontrolled. Okay, so keep that in mind. We want to address all of these different facets of pain to make sure that the pain overall, either lessens or is at least controlled somewhat. Lack of adequate pain management by healthcare providers increases anxiety and suffering in both the patient and the family. Okay, the use of pain medications in palliative care, including opioids and barbiturates, is acceptable and necessary in order to promote comfort and optimal quality of life. Now, keep in mind, the Centers for Disease Control and Prevention, or the CDC, guidelines for pain management and opioid use specifically state that the use of these drugs is necessary in end-of-life care. Now, that being said, even though they say it is necessary, there are guides that go with that. So make sure you're looking in your module, all right? Because I did upload the guidelines and checklists that the CDC has provided so beautifully for us to use as our guides when we are prescribing. So the most difficult end-of-life symptoms that have to be addressed are pain, respiratory distress, confusional states, and mild symptoms. Mild symptoms may cause severe distress, especially if the meaning of the symptom is frightening, like they think, certain symptoms are signifying that, death is coming, Several studies have demonstrated that these are the most difficult end-of-life symptoms to deal with. And some studies have showed that 16% of the patients require sedation to control pain and delirium. In another evaluations of patients during the last week of life, they assess patients at two intervals: their initial consultation and then during the last 7 days of life. Asthenia, anorexia, and dry mouth were the three most common symptoms in both periods, but the incidence of confusional states doubled during the last week of life. So that's something to keep in mind. If you're seeing your dying patient's confused state is increasing or suddenly worsening, then you know that the likelihood is they're going to be passing within the next week or so. So they did another study that assessed 400 patients that were referred to palliative care services and found that most prevalent symptoms in the cancer population were pain, anorexia, constipation, weakness, and dyspnea. All right. So they're pretty consistent across the board in terms of the most difficult end-of-life symptoms to deal with. Palliative management of dyspnea. So dyspnea can be a multidimensional symptom, meaning It occurs in about 75% of your heart failure patients and in patients with cancer or respiratory problems at a rate up to 90%. Oxygen, opioids, and benzodiazepines are the most widely prescribed medications for this problem. Oxygen, which must be medically ordered, is often the first treatment for dyspnea in end-of-life care. When you put a patient on hospice, they will be automatically given an oxygen concentrator. Decreased oxygen levels can cause confusion and anxiety in patients. However, not all dyspnea patients find oxygen therapy helpful, as it may cause breathing to slow. The best practice is to ask the patient if the oxygen makes them feel better, and if not, then they remove it. Opioids and benzodiazepines relieve feelings of breathlessness and the inability to take in enough air, which can cause anxiety and distress. You have to really reevaluate their effectiveness pretty frequently. And in terms of the oxygen, guys, yeah, if it makes them feel better, great. And if not, have them remove it. Sometimes they may not realize it's making them feel better. And if they take it off and then they're suddenly starting to get a little more confused or unclear, then you want to put it back on because it actually is helping them. They're just not even realizing it. Educate your family members too on how oxygen, not only is it just to make them feel better, it will also give them a little relief and help with the fatigue, because if they don't have to work so hard to breathe, it'll conserve their energy. So just educate the family members that oxygen is not a bad thing. The only bad thing about the oxygen that you also want to teach is, with fall prevention because of the oxygen cords. They're really, really risky for falls, all right? So terminal restlessness in your dying patient is often very upsetting to the family, of course. It's characterized by anguish, anxiety, agitation, or cognitive failure. It's an unsettling behavior. It's often upsetting to the family members because they think that it's caused by discomfort. And usually it's characterized, you see it with like fidgeting, moans, groans, grimaces. Causes for terminal restlessness include failing body organs, opioid toxicity, pain, drug interactions, and hypercalcemia. Medications to treat terminal restlessness include opioids, antihypnotics, antidepressants, antipsychotics, antiepileptics, and NSAIDs and steroids. But you can also consider your non-pharmacological solutions for restlessness that, again, you want to educate your family members on, which includes a calm and quiet environment, frequent reorientation of the patient to place and person, gentle touch, quiet voice, soothing music, candles, just keeping the environment super low key, super soft, nothing, too toxic, no clutter, not a lot of people, you want a very, very quiet, low key environment. This is where Florence Nightingale comes in with her very big on the, she had a lot of theories on the environment and just the report, having everything such a way so that everything was nice for the patient and the environment was very controlled. So the patient could focus on their inner self as opposed to their external environment. Palliative management of delirium. And then just management, again, we want to identify the underlying cause of the delirium and prescribe as appropriate. Environmental changes and supportive techniques, again, such as reducing unnecessary stimuli, reduction of anxiety. Usually we're treating them with chlorpromazine or haloperidol, which is the preferred drug. You're going to want to review table 20.13 and 2014 for your management of delirium. And then in terms of pain management, it's always a subjective experience. It's a complex problem, and the management of chronic pain requires an ongoing round of assessments, adjustments, and treatment. And you're going to want to differentiate your patient's type of pain because there are many different definitions of pain and types of pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience and states that pain is always subjective and can have a psychological or emotional foundation. A person's experience of pain is not always supported by evidence of tissue damage. Each person has a distinct level of pain tolerance or a distinct level of intensity of pain that is tolerable. The pain threshold is the lowest tolerable level in each individual in which a stimulus can cause pain. Nociceptive pain represents a normal response to injury of tissue. This type of pain is divided into two categories. Somatic, which arises from muscles and joints and cutaneous tissue, and 2, visceral. So we have somatic and visceral pain under nociceptive, and visceral pain is pain arising from organs and smooth muscle. Neuropathic pain is caused by impulses in the nervous system, diabetic neuropathy, post-herpetic neuralgia, post-amputation pain, and post-stroke pain are all examples of neuropathic pain, okay? Differentiating between nociceptive and neuropathic pain is important because these 2 types of pain require different types of treatments. Neuropathic pain, remember your neuropathic pain responds poorly to both opioid and NSAIDs, but often responds well to anti-epileptic drugs, antidepressants, and local anesthetics. So like your neuropathic pain, remember we're thinking Neurontin, right? That would be also an anti-epileptic drug. Your antidepressants and your local anesthetics are also treatments for your neuropathic pain. Now, remember, in terms of pain management, we got to differentiate. Are we having acute pain, chronic pain, and then look at our assessment. So remember, acute pain is normal, predictable, and it lasts a short time. It's caused by an infection injury, such as a broken bone, cut, contusion, or a surgical incision. This type of pain is not as difficult to manage as chronic pain because it's short term, and once the injury heals, the pain usually goes away. However, acute pain that is inadequately managed is thought to lead to chronic pain. So according to the American Pain Society, for the first line therapy for mild to moderate acute pain, acetaminophen or Tylenol or NSAIDs are recommended first line therapies. If short-term opioids are necessary, as with postoperative pain or a broken bone, combining the opioid with either acetaminophen or NSAIDs provides better pain relief than the opioid alone. If opioid pain relievers are required for severe acute pain, prescribing a short course of lower dose, short-acting opioid is preferable. If the patient continues to experience acute pain, careful management of opioid use is recommended. And then you have to reassess the pain at least every week to determine, what's going on with this patient and if it's being managed appropriately. Now, that's acute pain. Chronic pain lasts longer than 12 weeks and often persists long after the cause of pain is healed. Sometimes it may begin with no clear cause. There are many symptoms that accompany chronic pain, including fatigue, movement limitations, sleep disturbance, and decreased appetite. The goal of treatment in chronic pain is to reduce pain and improve function so that the patient can complete day-to-day activities. Often chronic pain cannot be cured, but it can be managed. So when we're going in to treat chronic pain, the first thing I usually say to the patient is, hi, listen, we're not looking to make this pain completely go away, but we are looking to make this pain more manageable than it is right now, because right now it's not manageable, but we need to make it low enough so that you can manage, it can be managed and you can do your day-to-day activities. So it definitely sets an expectation with the patient that, okay, I'm not going to be getting so much that I have no pain, but I'm going to be getting enough medication that I can control my pain and I can function. Chronic pain can limit activities, decrease productivity, and reduce the quality of life. So we want to make sure we get this under control. There really are no objective tests for assessment that can measure or locate pain empirically. Pain assessment is part of the patient's history. And because pain is personal and subjective, the patient's own description of the pain is really the only information the healthcare provider can obtain. Of course, when you're evaluating the pain, though, it's really important to identify and obtain a description of the pain. So don't forget old archives. Okay, so the opioid epidemic is a huge thing. Please look at your Johns Hopkins evidence-based program steps to, they basically came up with this to promote appropriate and safe use of prescription opioids. And basically it's to increase education, mandate prescriber prescription drug monitoring programs, which make sure once you get your DEA, you will have, you'll sign up for the prescription drug monitoring program. And that's basically a website that you go on that everybody who prescribes opioids can go on. And anybody who gets a prescription for an opioid, it gets logged into the system. So before you go to prescribe your patient some Percocet, let's say, you can go into this prescriber drug monitoring website and look up to see when the last time this patient was prescribed any sort of narcotic or opioid. And it'll tell you when, how many, who, what date, where they got it, like the whole thing. So if your patient says, oh, I haven't had it in 3 months, and meanwhile you look it up and they just got a prescription 2 weeks ago, you know we have a problem. Okay, so it's really important before you prescribe that you go onto this website and check it out. And there's a slide in a few slides that'll show you the CDC's information about that. Okay, so again, so the CDC has very clear guidelines for prescribing opioids. So you need to go into your module and look at all those resources that I uploaded and really understand the summary of recommendations from the CDC. It's basically aimed at changing clinical practice and promoting and improving communication between providers and patients. That is why they came up with this website, so that you could see the prescription drug monitoring program. There's a great deal of variation among states related to opioid prescribing and monitoring, but local pharmacies may have a database of patients and medication usage and can provide information related to opioid use too. So if you can't find the information in that particular prescription drug monitoring website, you could also call the local pharmacy, to, your patient's pharmacist, to discuss with them what's going on in terms of what's been prescribed for that patient. If the information is correct, you need to make sure you follow up with that. Because if the patient is saying that the system is incorrect, you need to find out if that's actually accurate. If the patients are found to have a history of taking high opioid dosages, dangerous combination medications, or multiple controlled substance prescriptions written by multiple providers, the clinician, you should then be discussing safety concerns such as respiratory depression, the risk of overdose and death with patients, especially when opioids are combined with benzos. All right, guys, so make sure you're having these really heart-to-heart educational talks with your patients. Here's the website to look at all the different prescribing clinical tools they have on the CDC. They have webinars, they have tons of information about pain management, palliative care, all this stuff on your CDC website. So please check that out. Here's your guidelines. They give you a beautiful, clear guideline on prescribing opioids for chronic pain. They talk about references as to why they're giving you these guidelines and recommendations. Right over here, here's your checklist for prescribing opioids for chronic pain. It talks about when considering long-term opioid therapy, what you would do. Then if the patient comes in to renew, if renewing without a patient visit, what do? You check that the return visit is scheduled in less than 3 months from the last visit, right? So they have all these guidelines to really make sure everything stays on point. And then over here on the right-hand side, they give you references as to why they came up with these guidelines and came up with this checklist, and what, in addition to these particular guidelines, what other things you need to check or how you need to refer. Excellent resources, guys. I can't stress it enough. Also, the app on the phone, you're going to want to go ahead and download that. It's just right there, so you can access all these tools very quickly and easily. It's posted under the links for all these resources are posted within your module under additional material. Okay, they give you non-opioid treatments for chronic pain. They give you identifying risk when prescribing opioids. So these resources are also excellent tools to have within your primary care practice and kind of do maybe an in-service to all the patients, the staff within your practice. Remember, your role as a nurse practitioner may be to keep your practice and the practitioners within your practice up to date on the most recent guidelines and standards of practice. Okay, so non-pharmacological treatments for pain include acupuncture, the TENS unit, massage, gentle exercise programs, distraction from pain, mindful therapies. You also have Reiki. Don't forget about Reiki. It's extremely helpful, especially in your cancer patients in terms of pain management. And again, the CDC gives you a whole fact sheet about the prescription drug monitoring programs and an initial, why the importance of it and how you as a practitioner can utilize it. So definitely check that out as well. Every state has its own version of that. So you're going to want to look into Connecticut's. Once you get your DEA, you'll have access to it. All right, guys, that's pretty much it. It's a lot of material. I hope you guys don't go crazy, but again, it's not that you need to memorize it, but you need to understand where all this stuff is coming from and how to access it when you need it. especially when it comes to sports physicals, CDC guidelines for pain management, prescribing is based on CDC guidelines. These are all really important things. Also, your American Heart Association guidelines in terms of your pre-sports physicals and your cardiovascular concerns. All right, those are the things you need to really make sure you review and just are very aware of, and just really understand what the main principles are behind them. Next week is module 12. We're getting there, guys. We're almost done. I'm so proud of you. Next week, again, a lot of reading, but pretty consistent in terms of just the different psychological issues. And I wanted to make sure that you are aware of the DSM-5. If you have never heard of that, just keep in mind that is a diagnostic and statistical manual of the mental disorders, and it basically holds all the codes of diagnoses. It's a classification system. So your textbook constantly refers back to the DSM-5. I just wanted to make you aware that that is a book that exists, and it is used specifically to diagnose mental disorders. Okay. So that's it, guys. If you have any questions or concerns, please send me an email. If you wanted to meet to discuss anything, please, again, just shoot me an email. I hope you have a great week and happy studying. Thanks, guys.